Well, if you don't mind, I'm going to speak first about organ donation because I talked too much about other stuff before. And I'm not going to deal with organ donation of a kidney or a part of a liver or lung from a healthy person to help someone who's sick. That's a topic for another day. It might be controversial, but it's not one that I like to deal with. You know, in order to donate organs, we have to follow what's called the dead donor rule. Patients must be declared dead before the removal of organs for transplantation. But note that must be declared dead is not the same thing as must be dead. Words matter. In 1968, a committee at the Harvard Medical School suggested revising the definition of death so that patients with devastating neurologic injury could be used as organ donors. The brain death concept was created at this meeting. Among the tests that are done to determine brain death is a test called the apnea test. In this test, the ventilator can be shut off for about 10 minutes while they see if the patient will start to breathe on his or her own. If the patient does not breathe on his or her own, she or he are put back on the ventilator and considered brain dead. I mean, there's other tests that they do. I'm simplifying this, but this is a very dangerous test because the carbon dioxide level builds up during those 10 minutes in these patients and can only cause more harm to a patient who's already neurologically compromised. And it is not something you want to do to somebody to find out if they're dead. The only thing that the apnea test really proves is that the person needs a ventilator. It doesn't prove that they're dead. And on my desk out there, there are some little brown pamphlets written by Dr. Paul Byrne about the apnea test. And I know they're almost all gone, so I know that many of you have them. The most important question is, are organ donors really dead? This ought to be viewed as a fundamental pro-life question. We shouldn't duck and say, well, you know, it's accepted medical practice. Well, a lot of things are accepted medical practice. Abortion is. Taking away food and fluids from patients is. There's a lot of things. Embryo research is. So there's a lot of things that I disagree with in current medical practice. Many of the medical community have expressed doubts that brain death is true death, and some of them are certain that brain death is not true death. So we at least, when there's a question, we should err on the side of life. We shouldn't just go blindly ahead and say, well, you know, we need these organs for transplant, and anybody who questions brain death is going to cause other people to die because they won't have the organs that they need. Well, when you're taking organs from a living person to give them to another person, you are killing someone. And so let's examine today whether or not brain dead patients are really dead, or whether any organ donor is really dead. There's another protocol called donation after cardiac death that we're going to talk about also. Donation after brain death. Under the Uniform Determination of Death Act, all hospitals are allowed to set their own standards for determining brain death. So in one hospital, you could be considered alive and in need of treatment, and in another hospital, you could be considered dead. That's confusing. A dead body is a cadaver. Death is the absence of life. Okay, but a brain dead patient appears to be alive. Are our eyes deceiving us? They're warm, they're pink, they have a blood pressure, the beating heart, they're breathing with ventilator support. They digest food, excrete waste, grow, heal, mature. They can even carry a baby to term if they happen to be pregnant and produce milk. A brain dead donor is given a paralyzing drug before the first incision is made, in order to prevent them from squirming and grimacing. A cadaver does not squirm or grimace. The reason that they started giving the paralyzing drugs is because this was disturbing the transplant team. Nurses and anesthetists were getting concerned that these patients who were supposed to be dead were moving. Even paralyzed, their pulse races, their blood pressure raises. In England, donors are given an anesthesia in case they can feel pain. In the United States, most of the time they're not. Proponents of brain death assure us that we have nothing to fear when rigorous criteria are followed for determining brain death. But you can tell that to Zach Dunlap and Stephen Thorpe and a number of other people that I have in my files. Zach Dunlap, in November of 2007, was a 21-year-old Oklahoman. He wiped out on his four-wheeler and suffered catastrophic head injuries. He was flown to a hospital in Wichita Falls, Texas, and 3 days later, or 36 hours later, he was determined to be brain dead. His family even says they used every test to be sure that he was brain dead. They even did a blood flow test where they put dye in to make sure there's no blood flow to the brain. Everything pointed to the fact that he was brain dead. But Zach heard them declare him dead. His family and his friends were there to say goodbye to him when his cousin, who was a nurse, scraped his pocket knife along the bottom of Zach's foot just to make sure before they started the organ procurement process. And Zach moved his foot, and it was stopped. Zach recalls hearing them declare him dead and asked that his organs be donated. He wanted to get out of bed and sock somebody, but he couldn't move. Zach is now walking and talking and made almost a full recovery. A few weeks ago, a young British man named Stephen Thorpe revealed to the media that his father saved his life. 4 doctors had declared him brain dead. They all agreed there was no hope for him. But 5 weeks after, his father wouldn't let him die. He wouldn't let him be an organ donor. And so 5 weeks later, Stephen walked out of the hospital completely recovered. Recoveries like Zach's and Stephen's should at least make us wonder, are brain death criteria sufficient for determining that a person is really dead? If we can't answer that question, should we be taking organs from people who are declared brain dead? Such cases are just a warning. Some physicians, even who agree with organ donation and with brain death, tell us that physicians will not always be careful in the administration of these tests and may prematurely declare a person to be dead. So even those who are in favor of brain death and who are in favor of vital organ donation or organ donation will admit that some doctors aren't real careful. Well, how do you know which doctor you're going to get? So brain death is not, I would never become an organ donor because someone had declared me brain dead. Then there's donation after cardiac death, and few people are aware of this kind of donation, and only a small percentage of organ donation is done from cardiac dead patients. Donation by cardiac death protocols allow patients who are not brain dead, perhaps not even brain injured, to refuse resuscitation, to have a DNR order written, to ask to be taken off the ventilator, and then to donate their organs. It kind of ties the right to die or euthanasia with organ donation. A patient or a family can agree to do this, and then the patient is removed from the ventilator and in surgery usually, so the family's not even with them when they die. They usually take them to the surgery and then remove them from the ventilator. And they wait up to an hour hovering over the person, checking their pulse to make sure that they're pulseless when they become pulseless. And as soon as they feel no pulse, remind you, this doesn't mean there's no circulation. There can be some circulation, there can be other signs of life, but as long as they can't feel a pulse, they start in 75 seconds to 5 minutes after the person is pulseless, they will start cutting to take out the organs. So the person isn't brain dead, because a person can be resuscitated. If they intend to resuscitate this person, they would be considered alive. But because they intend to take their organs, they're considered dead. That is also confusing. Now, doctors in Belgium are using donation after cardiac death protocol, but instead of removing patients from ventilators, they're giving patients the lethal injection and then taking their organs. Both brain death and cardiac death are hastily declared because once the person is truly dead, the organs are useless. If they wait the amount of time necessary to know that a person is really dead, their organs have already begun to deteriorate. And so they have to take them as quickly as possible while they're as fresh as possible, and preferably while there's still some circulation or the organs are being perfused with fluids, so that they're fresh and usable for the next person. Organ transplantation is a billion-dollar industry. If the organs dry up, the dollars dry up. This is the most lucrative business in medicine. Money is what drives this. It's not really, so few people get organs from organ donors. And those that do, many of them have terrible complications afterwards. And some of them have said if they knew ahead of time what was going to happen to them after they got their new organ, they would never have had an organ transplant. They would rather be dead. They have to be on anti-rejection medication for the rest of their lives, and other things happen to them. Also in 2006, the Uniform Anatomical Gift Act was revised, and in 2009, Minnesota adopted this revised Uniform Anatomical Gift Act. And most people do not know that their law has been changed. In 40-some states now have accepted the revised Uniform Anatomical Gift Act. This means that this new law requires you to explicitly refuse in writing to be a donor if you don't want to be considered a prospective donor, and if you don't want them to assume that your intent is to be a donor. Let me explain what this means. It's not enough to say no to organ donation on your driver's license. That is not considered a refusal. According to the new law, a person who says no on their driver's license, or a person who hasn't said yes to be an organ donor, can be presumed to intend to be an organ donor until somebody else either consents or refuses for them. So in other words, you can say, no, I don't want to be an organ donor on your driver's license. Or you can revoke a previous gift that you made, but you will still be considered a prospective organ donor if you haven't signed something absolutely refusing to be an organ donor. They can do all kinds. When you are at or near death, and those are the words in the law, you're not dead, you're at or near death, the hospital is required to call the organ procurement organization, and they will come and they will look through all your medical records, invade your privacy without anyone's permission or consent. This is one of the things under HIPAA that can be done without your permission. They will run tests on you to see if your organs are suitable for transplantation. They can do things to you, such as put you on a heart-lung machine, or give you heparin to thin your blood, or perfuse you with fluids. They can do these things to you without your permission, without your family's consent. And while they're doing these things, they can be searching for someone to give their consent or to refuse to donate your organs. There's a whole list of priority people in the law. And the last one is anyone who has the duty to dispose of your body. So in other words, if they can't quickly find a relative or a friend to refuse or consent to your organ donation, the person who's disposing of your body can determine whether or not you are an organ donor. I know this is all kind of confusing. The law itself is a tangled web, and I think it's intentional. I really think that some of these things are written so we won't understand what they mean, or so that they can say, oh no, that's not what it means. But this is what it means. It means that they can call real quickly all the people, like your parents, if you're a kid. You can be 16 years old and have, and have your organs taken because you're old enough to get a driver's license. It is the most, I have read this law over and over and over again, and every time I see something new in it that's scary. So I would advise you, if you're thinking about being an organ donor, to rethink it. And I would ask everyone to consider signing a refusal and carrying it in your wallet, and also attaching an addendum that says the same thing to your advance directive, so that nobody can say, well, we didn't know that they refused to be a donor, so we presumed their intent was to be a donor. It used to be that they couldn't take your organs unless you had consented or someone in your family had consented. And they still can't. But they can do all these other things to you until they find someone who will consent. The revised UAGA infringes on your right of privacy, your right of informed consent, your right to security of person, and your right to life. And to me, it's appalling to think that your organs are more important than you are. That they don't care about you once you're in a compromised situation health-wise. It's your organs they want. Many people support organ donation because they trust the ethical standards of the medical profession. I simply can't share that trust any longer. And believe me, in 1985, I believed in being an organ donor. I promoted organ donation. I thought it was a wonderful thing. And it took a lot of arm twisting and people telling me, Julie, how can you think that's okay? This happened, that happened, and showing me many cases, and I finally changed my mind. I have signed and witnessed a refusal to donate organs, and I've attached it to my PMDD. I carry it in my wallet, and I think it's the only safe thing to do. There's no state registry that allows you to register your refusal. So you have to carry it on your person. You have to tell every person you know you refuse to be an organ donor, and you all just heard me. So you're my witnesses. Next, patient advocacy. This is what I really wanted to talk to you about today. This is where my heart lies. For 27 years, as I mentioned this morning, I've been a volunteer patient advocate. To illustrate some of the points I'm going to make, I'm going to tell you some stories. But I want to tell you about one man in particular who I absolutely adored. His name was Jewel, and he was a jewel. He was kind of not a real bright old elderly man. And I got to know him because I would go to visit his wife who had lung cancer, and I would take care of her. Well, she would always chase Jewel out of the room because I was her company, and Jewel would meekly go. Well, Avenel died, but we were all at the hospital the night that Avenel died, and here was little Jewel hovering over Avenel. Oh, Avenel, Avenel, what should I do? And Avenel looks at him with her dying breath and says, "Pray, stupid." You know, those are moments that you treasure for a lifetime. And Jewel was such he was just like a butterfly that had come out of a cocoon when Avenel died. I would go over there and we would bake cherry pies and make stews and stuff to put in his freezer, and I'd show him how to clean house. He'd never done anything for himself, and he learned how to be independent. And he would come to our house for dinner on Sundays, and I never get my kids' names straight. He would always call Kevin Calvin, and but he was just a gem. He had cancer of the prostate, and I would take him to his appointments at the vet's hospital, and I would help him communicate with the doctors, and he was so grateful for everything that I did for him. And this just sort of gave me a taste for how wonderful it was. Not every patient is like Jewel, but he was a jewel, and he is still my favorite. Hopefully this presentation will help you think more clearly about the complex issues of compassionate care for the sick, the severely disabled, and the frail elderly. I also want to talk to you about respect, not just for the patient, but for their family and for everyone, even if they don't agree with us, even if we don't see eye to eye. We must have respect for these people. I always say that anybody who is not pro-life is just one of our allies in waiting. All we have to do is be patient, and one day they will come to us. I cannot tell you the number of calls that I get from people who, after the fact, after someone has died, call and say, I know my mother died from the decisions that we made, and I feel so guilty. Can I talk about it? And we talk them through it, and it's just like post-abortion syndrome. They need help. They don't need our condemnation. They have been misled by this, I call it a euthanasia juggernaut. It is running roughshod over all of us. That they just don't know what they're doing. And once they realize what they're doing, it's just like a woman who's had an abortion. They need someone who understands. They need someone to talk to. And that's another aspect of advocacy that's very important. And then I want to talk to you, finally, about death with dignity and what it really means. And honestly, I'm here to recruit every single one of you, because there's never been such an urgent need for people to take care of other people, to be their last friends. These are terrifying times for people who can't speak for themselves. If you fell ill tonight and you couldn't speak for yourself, you couldn't move and you couldn't cry, who would speak for you? You are in danger, more danger than ever before, of someone making a decision to kill you. And to me, that's a terrifying thought. It's not that I'm afraid to die. In fact, I think those who push for the right to die are the ones who are afraid to die, and they want to hurry up and get it over with because they can't face it. But for those of us who are not afraid to die, we want to die in God's good time. We don't want to, as I said earlier, show up uninvited. We are on the edge, on the threshold of a mass geriatric society. This creates enormous challenges for every family and for all of society, and we have to learn how to deal with this. How are we going to care for each other in this situation? We know that government programs are not going to take care of us. We need to take care of each other. A great deal goes on out of the sight of the public view, and that's why we're calling this conference Stealth Euthanasia. I want to tell you about my sister, Nanette. Nanette is wonderful. She takes care of all the elderly relatives, and I mean we have had a bunch. But she's here today, and she is a big part of the story that I'm about to tell you about our elderly Aunt Louise. Louise was admitted to the hospital with a gastrointestinal bleed. She was bleeding somewhere in her gastrointestinal tract, and they didn't know what was causing it. She was almost blind and pretty deaf, and she was admitted to the in-hospital hospice after a little while. And Nan called all of us. We come from a large family, and a bunch of us sisters descended on Duluth, Minnesota from all over the state of Wisconsin. I was living in central Wisconsin at the time. And we came from all over, and we found out when we got there that her IV had been removed, and she was not getting any food and fluids. And when I asked the nurse why, she said that she was on supportive care only, that her healthcare agent had agreed with that decision that the nurses had made. And her agent was our cousin, who was her oldest daughter. She lived in Michigan, and she wasn't even there to make decisions. We were all there. The nurse said that Louise wasn't responsive and that she was expected to die soon. Nanette, who was a regular visitor to Louise and knew how to communicate with her, walked up to Louise and rubbed her arm and spoke into her one halfway decent ear very loudly, and Louise was very responsive. She said she hurt all over, especially her leg. They had taken the dressing off of her leg that had a large open wound, and they hadn't replaced it, and it was open to the air. And so we went and we asked them to take care of that, and we asked for pain medication. It took them over an hour and several requests to bring her pain medication, and I don't even know when they put the bandage back on her leg or dressed her wound, but it took for a very long time. Our sister Paula went and asked them to dress the wound, and they said they would, but they had to order the dressing from the pharmacy. Well, when we left that evening, I don't think they had the dressing yet. Her lips and tongue were dry, and I asked her if she wanted something to drink, and she said, yes, 7-Up, please. And so we brought her 7-Up. This woman could not hear, but they had a harp player stationed outside of her door playing music for her, but they wouldn't give her a sip of water. We visited with her that evening. We prayed the rosary, and when we left, we asked the nurses to continue to give her fluids. When my sister Sue and I returned the next morning, they hadn't given her anything to drink. So we gave her some more 7-Up, and we waited for the doctor. And when the resident hospice doctor showed up, we confronted her with the lack of care and the poor treatment that Louise was getting. We told her that Louise could communicate and that she wanted to eat and drink, but apparently the nurses had charted that she was unresponsive. Even though Nanette had shown them how to communicate with her, they hadn't tried. The doctor asked if we thought Louise was able to make her own decisions, and we said yes. So the doctor tried to talk to Louise, but she talked in a soft voice, and she asked questions that Louise couldn't have possibly understood. And so I said, let me try. And I bent down, touched Louise's forehead, bent down, yelled in her ear, Louise, are you thirsty? And she said, yes. And I said, do you want the doctor to find out, do more tests to put a tube down and find out why you have this bleed? It was almost gone by then. And she said, no. And so then I said, do you want, to the doctor, I said, do you want me to ask any more questions? And the doctor said, no, that's fine. And she proceeded to write in Louise's chart that Louise would now be making all her own decisions from now on, and that she ordered a full liquid diet for her. A couple of days later, Louise went back to her nursing home, and Nan would visit her all the time and feed her meals and give her sips of wine, and she was eating solid food. And she lived for 3 more weeks. And thanks to Nanette, we have the comfort of knowing that she didn't die of dehydration. She died of natural causes. And just recently, our aunt, Bev, is in the nursing home, and she had signed a living will. We've convinced her to get rid of it and sign a protective medical decisions document instead. So those are the little things that you can do. You can be a relative, you can be a friend, you can be a volunteer, you can be a professional, but we all can be other people's patient advocates. A patient advocate is anybody who strives to safeguard the welfare of a patient in the healthcare system. Anyone who's a voice for someone who cannot speak for himself or herself. Particularly in need are those who are devalued or defenseless, because there are so many people that have no one to defend their lives or to protect them from abuse or to just love them. It is one of the most gratifying things I have ever done is to help people who have no one else to help them. We usually learn to do what we do by doing it, because everybody's an individual. But on my table, I have kind of something to start you off with on how to be a patient advocate, if you want to pick up something. Every Patient advocate brings their own special abilities, and what counts most is your loving presence, not what you do. So if you're not comfortable doing something, don't do it. Just be there for the patient and make sure it gets done by somebody. This may sound obvious, but genuinely caring about the person, loving the person, is the secret to being a good patient advocate. You don't have to have any intelligence, any special intelligence. You don't have to know anything. You just need to love the person. I make it a rule to be the primary patient advocate for only one person at a time, because otherwise you risk burning out or you're not available when you're needed. But that doesn't mean you can't help other people. It means that this patient is your focus. And you don't want to burn yourself out. You have to remember that your family comes first. You put your family's needs first. But the patient that you've made a commitment to is the one that you need to protect. And that includes finding other volunteers to visit the person, scheduling them so that if it's a really particularly vulnerable patient, that there's somebody there with them 24/7. Some people are afraid to go to sleep if there's nobody in the room with them, or if their door gets closed. And some people don't get their call bells answered as soon as they need to be, or there's nobody to run for help when it's a real emergency. So somebody who's really vulnerable in a healthcare situation needs somebody there with them 24/7, and a patient advocate doesn't have to be there. You can enlist people from your church or their relatives or whatever and schedule them so that somebody's there all of the time. I want to tell you about, sometimes, you just answer people's questions too. One time I got a call from a family at our church, and their father was in a hospital in Marshfield, Wisconsin, and he was in a coma. At least that's what the family was told. He had had surgery, open heart surgery, and then afterwards he'd had a major stroke. And they were telling the family that it was time to remove him from the ventilator and take away his food and fluids. And so the family contacted me wanting to know what to do. Well, I found out that the man had not only was given a morphine drip, but he also had a fentanyl patch. Fentanyl is another opioid, and it is not supposed to be given to anyone unless they're already opioid dependent. It's not supposed to be given post-surgically. All of the things that it's not supposed to be given for, he was being given it anyway. And I told the family to get him off the fentanyl patch. They did, and a couple of days later, his wife walks into the room after it had gotten out of his system, and he's laying there and he says to her, "What's for breakfast?" And this is a man they said would never recognize his family again. So sometimes I think they are deliberately keeping people in a comatose state so that they can kill them. He is alive today, and this is like 6.5 years later. Oh, here is the drug report that I received just a week before I found out that Jude was on the fentanyl patch. Talk about God's providence. It has all of the contraindications for using the fentanyl patch. It tells you how it suppresses breathing. And as soon as they got him off of that, also he didn't need the ventilator. He started breathing. So sometimes coincidences happen. I don't know, maybe they're God incidences, but this came to me just a week before I could use it for Jude. And when you're a patient advocate, things like that happen. How much time do I have left? About 10 minutes, okay. What does a PA do, or a patient advocate? I call him a PA. I say that they do works of mercy. Mercy is putting your kindly inclinations, which we're so often tempted to ignore, into action. You can drive someone or accompany them to doctor appointments. You can take notes for them at the doctor. You can ask the questions the patient wants asked. You can compile a list of the patient's symptoms and questions before you go to the doctor. You can do research to help them find the pain specialist they need or the physical therapy they need. they're given hope just by the fact that you're there, that somebody really, really genuinely cares about them. Dr. Paul Byrne, the author of the essays in this book that's on my table, oops, I'm not on the right page, the Life Guardian booklet, has a really unique idea, and I don't know how this is going to work, but I think it's a great idea. It's a directions to protect and preserve the life and health care representative serving as agent for a dependent person who is a minor or medically incapacitated person. It's an advance directive that someone who wants to protect the life of a patient makes out for the patient who can't speak for himself and has it put in their medical record. Now, he's a physician, so I presume he would follow this, and I'm sure many pro-life physicians would follow it. And I would just ask you to pick it up and look at it, because it is a unique idea that I've never seen before. Many hospitals and nursing homes are short-staffed, and visitors can soothe restless patients and demanding patients, and by doing that, they can prevent the overuse of sedatives or tranquilizers, whatever, or restraints. I had a patient, my first actual experience of trying to be a patient advocate was in Montana. My next door neighbor was admitted to the hospital with a kidney infection. Jane was an elderly lady, but she walked 2-3 miles in the hills around Billings every single day, and she was healthy. And then she got a kidney infection, and she ended up in the hospital. And they put her on Haldol because at night she would get restless. And Haldol is, I guess you call it a tranquilizer, but it often paralyzes the throat muscles too, so a person can't swallow. When she lost her ability to swallow, they didn't give her an IV, they did not give her a feeding tube or anything, they were just going to let her die. And I protested. I went to her daughter, who was 72, and I said, you have to get the doctor to take her off of Haldol, because I checked with the pharmacist and he says this is what made her not able to swallow. So the doctor refused to take her off of Haldol. We had to find another doctor for Jane in order to get her off of that medication, and then we had to get a speech therapist to teach her how to swallow again. So those are just some of the things that I've found that I can do that surprise me. But the most surprising thing I found out I was capable of doing was going to court. Now, if you think confronting a doctor is scary, try confronting an attorney who has been appointed by the court to advocate for a person's right to die. A number of years ago in Texas, I got a call from a family whose daughter-in-law was being starved in a rehab hospital in Fort Worth. She'd been shot in the head twice at point-blank range in a drug deal gone bad. She was the kind of person who's really devalued by society. She was a prostitute. She'd been married 4 times. Her children had all been taken away from her. I mean, she'd had multiple abortions. Her life was a mess. And when the hospital told her, this drug addict, that they could keep her comfortable while she died by dehydration, she leapt at the chance because it meant drugs. Well, her family was concerned. They called me in, and they said, what can we do? So I went to talk to Terry, and Terry was a Catholic, I found out, but Terry couldn't speak. She was tube-fed, but she could communicate with her eyes, and so we used a letter board, and I'd say the letters, and she'd blink when I got to the right one. It was a very laborious process, but we eventually got a shorthand for it. But I asked her why she wanted to die, and she said because she wanted to go to heaven. And I looked her in the eye, and I said, but Terry, you may just be jumping right out of the frying pan into the fire. I said, don't you want to think about this? And she spelled, okay, I'll think about it. When the hospital found out she was thinking about whether or not she wanted to die, they got a court-appointed attorney ad litem to defend her right to die because we were interfering with her rights. We got a pro-life psychiatrist to come and examine her, and say that she was suffering from post-traumatic stress syndrome, and we went to court and we moved her to a safe house for a while. Thank you. And Terry lived for another 6.5 years and died peacefully in her sleep. We got her a power chair where she could get around with her head working the chair. We got her a computer with a voice. We would visit her. We got lots of volunteers to go see her. And we also got a private detective and found one of her sons and would have him come and visit her regularly. And so Terry's life became very livable. And she couldn't get her drugs anymore. So she turned into a genuine, wonderful human being. Now I want to talk to you about death with dignity. A good and dignified death is not determined by timing, convenience, cost control, the family's suffering, or even by the patient's anguished request to die. Human dignity does not rest on fragile independence. We are all dependent on each other. We all need to cherish each other. Our life here is important, and everything we do matters, even how we die. A dignified death comes at the end of a life well lived. And those of us who are sick, disabled, or old have a moral obligation to accept the care we need. Medical care, of course, but personal care, even from strangers who become volunteers, who become friends eventually. And I want to leave you with just a couple of thoughts. When I've debated people on this issue, I have told them that if I agreed with them, we would both be wrong. And what do you say to somebody? You start thinking now about what you're going to say to the people who favor the right to die or euthanasia or assisted suicide or any of these things. Here's what I say. According to the opinion polls, it looks like you're going to win. You're going to have it your way. But you're going to know what you're doing because I'm going to keep on telling you. And we know you have a conscience, and we're never going to stop appealing to it. And I'll leave you with the words of Mother Teresa of Calcutta. Never worry about numbers. Help one person at a time, and always start with the person nearest you. Thank you.